This is an eye of a patient with history of pars-plana vitrectomy for endophthalmitis, who presented now with a white intumescent cataract. We are performing Phacoemulsification, our standard technique, on 2.2 millimeter incision on topical anesthesia. Of course, the main issues here are related to the intumescence of the cataract, so we need to dye the anterior capsule, and we need to use big quantity of OVD to fill the anterior chamber with viscocohesive OVD, which will push the anterior capsule, trying to avoid as much as possible, when we puncture the anterior capsule, the sudden egress of the cortex, which we assume is more or less liquefied. That's why we use either the needle. In this case, we use instead of cystitome, we use coaxial forceps for capsulorhexis via paracentesis. Now we enter with a cannula attached to a syringe, through which we aspirate the cortex. Thus we try to decompress a bit the cortex. The cortex is not 100% liquefied, but still it is under pressure in the bag. So again, we need to inject OVD. OVD must be injected on the anterior capsule, so we pay attention not to inject it in the break performed in the anterior capsule. Again, we aspirate a bit the cortex, paying attention to avoid the migration of the opening towards the periphery. And this is what it was almost happening, a bit of migration of the anterior capsule opening towards the 12 o'clock. At that moment we stopped the cortex aspiration, and with the same forceps via paracentesis we performed the CCC. It's better to do it smaller than desired, instead of doing it too big, because when you aim to do a larger capsulorhexis, the danger to run out is much bigger. So we can try a compromise to perform it a bit smaller at the beginning. We will do afterwards the phacoemulsification, and at the end we may enlarge it if it is necessary. The capsulorhexis is not perfectly round, but its center is continuous. The main goal is to be continuous, so we don't want to have run out of the capsulorhexis. It is continuous and wide enough to allow us to perform safe phacoemulsification. And this is what we do in cases like this with white cataract. We assume that the nucleus is quite soft, and it is indeed. As you see, we can aspirate the epinucleus and even the nucleus with very low level of torsional ultrasound energy. And at a certain point, after we saw that the nucleus is almost already gone, under OVD, we will continue with the bimanual irrigation aspiration of the epinucleus and cortex. And indeed, this is a young patient, 50 years old, so we were prepared to find more or less soft nucleus. So in this case, the main problem, the main issue was the capsulorhexis, but not the phacoemulsification itself. You can see the parameters on the screen. My IOP is 34-36 as a standard, and now I notice opacification of the posterior capsule, for which I intend to perform a polishing. The polishing of the posterior capsule is in my standard technique for all phaco surgeries, but in this case I could assume that the posterior capsule is more sensitive, let's say, prone to be broken, and this is what it happened here. At that point, I stopped the polishing. I entered with OVD via left paracentesis while maintaining the irrigation cannula in the right paracentesis. And I withdrew the cannula only when my anterior chamber and bag was filled with OVD. I'm using the same forceps which I normally use in biaxial cataract surgery for small incisions, 1.6 incisions for example. And with this forceps I perform posterior capsulorhexis. Let's not forget, this eye is a vitrectomized eye, so we don't have vitreous there at all. It is only BSS, so it is even better that we performed posterior capsulorhexis, which is not that risky as in eyes with vitreous in the vitreous cavity. The posterior capsulorhexis is ready. It has a diameter a bit smaller than the anterior capsulorhexis, and we are prepared for PC-IOL implantation. This is AMO IOL with their special dedicated cartridge and with a screwing injector. In cases like this, when you have posterior capsulorhexis, it's better to enlarge a bit the incision in order to be inside the eye, inside the bag, when you inject the IOL. It's much safer than to inject it from the wound-assisted technique and with a spring injector. So we use the screwing injector. We are with the cartridge in the anterior chamber, but because the posterior capsulorhexis was relatively big, I preferred to have it first, to have the IOL injected first in the anterior chamber on the iris, and then with the gentle posterior pushing and rotation maneuvers, I put the IOL step by step, first the first haptic and then the second haptic in the bag between the posterior capsulorhexis and the anterior capsulorhexis. Now the IOL is very well centered in the bag. I just have to wash the viscoelastic in the anterior chamber and under the IOL, and the surgery is more or less ready. The pupil is not very large, so in some incidents you don't see very well the red reflex, but under irrigation cannula you can push a bit the eye so you can see better the red reflex, and I decide for enlargement of sort of fine-tuning the initial capsulorhexis, which was a bit too small, and I'm quite happy with anterior capsulorhexis size and with the IOL position in the bag. This is how the eye looked in the first post-op day, and here you, with the green arrow, you can see the posterior CCC, and with the gray arrows you can see the anterior capsulorhexis. Thank you.